To finish off the day, it is my pleasure to introduce Dr. Carla Roman-Montes from Instituto Nacional de Ciencias, Medicas y Nutricion, Salvador, Zubiran, which is the flagship hospital for Mexican NIH. And Dr. Roman-Montes is an attending in infectious diseases who also works in the microbiology laboratory and is doing a master's currently in medical science. Dr. Roman-Montes will be presenting their experience in invasive fungal infections in critically ill patients in Mexico City.
Thank you, Doctor. Hello, everyone. I am Carla Roman from Mexico City, and I'm going to talk to you about our work that is titled Invasive Fungal Infections in Critical Ill Patients with COVID-19 in Mexico City. Thank you for the opportunity. Well, first, I want to tell you about our center. The Instituto Nacional de Ciencias, Medicas y Nutricion Salvador Zubiran is a tertiary care center in Mexico City that had 160 patient beds in wards, 14 intensive care units, and only 8 intermediate care unit beds. In March 2020, the Institute conversion into a COVID-19 center. For this, increased to 15 intensive care unit beds, handled by non-critical care physicians and nursing, and in area that not designed for critical patients. Until October 2021, more than 3,000 hospitalizations and more than 10,000 ambulatory care COVID patients was admitted. Well, as we have seen in all the day, the spectrum of COVID-19 associated fungal infections is big and faces a diagnostics and challenge and diagnosis and treatment challenge. And we know that the fungals that are more frequent involved in fungal infections are Aspergillus, Candida, and Mucorales. For this, our objective was to describe incidence, prevalence, clinical and microbiological characteristics and outcome of critical ill COVID-19 patients with invasive fungal infections. Well, about methods, we conducted a retrospective study. We revised all patients that admitted to any critical unit between March 2020 to April 2021. We revised demographical, clinical, and microbiological data from the electronic medical report. And we include all patients who develop an invasive fungal infection during hospital stay. We consider these criteria for invasive fungal infections, and we matched age and sex controls who did not develop fungal infection who compared with characteristics. We report an outcomes, especially hospital mortality, intensive care unit stay length, and hospital length stay. The protocol was approved by Ethics and Research Committee. Well, I showed you our results. We found an 8% patients who developed fungal infections during ICU stay. We showed you that most were male. The mean age was 57 years, and the most than 50% was obesity, and the comorbidities are more frequent were diabetes type 2 and hypertension. As you can see, no basal difference were seen. Fungal infections, the most frequent fungal infection was Kappa with more than 15%, followed of invasive candidiasis with almost 36%, being the most common candidemia. And we have 3 cases of mucormycosis and 3 cases of pulmonary cryptococcosis. The days from ICU admission to invasive fungal infections was 9 days, a median of 9 days. And 85% receive antifungal. Well, about outcomes of these patients, we found an important difference between patients with invasive fungal infections and versus non-invasive fungal infections in hospital stay length and intensive care unit stay in median days and duration on ventilator median days. All were longer in patients with invasive fungal infections when compared with patients that not have invasive fungal infections with a statistical significance. About COVID-19 associated pulmonary aspergillosis, CAPA, we have 78% of possible CAPA cases and only 22% of probable CAPA cases with AMM-ISHAM criteria, but all met as ICU criteria for putative pulmonary aspergillosis. We have 33 positive aspergillosis cultures, 31 from tracheal aspirates, and only 2 from bronchoalveolar lavage. And Aspergillus fumigatus was the most frequent species isolate, and none with azole resistance by microdilution. Well, we have eight cases, 22% with a HAT positive serum galactomannan antigen. About 97% with tomography for CAPA diagnosis. The most findings were 57 with ground glass infiltrate progression, 11 with micronodules, 5% with consolidations, and only 1 case with a cavitation. 81% received antifungal treatment, was voriconazole the most frequent in 93%, and we found an 59% hospital mortality rate versus 33% than other IFI, or 47% without invasive fungal infections. That is important because this percentage is greater than other groups. About COVID-19 associated candidiasis, we found 22 candidemias and 2 proven pulmonary pleural infections. The most frequent species was Candida parapsilosis in 15%, followed by Candida albicans and Candida glabrata. 79% had a prone position during intensive care unit stay, and 100% with venous catheter central with 30 median days from placement to candidemia, and none had total parenteral nutrition. None of these cases with persistent candidemia. 25% have an ophthalmological evaluation during the candidiasis, and 8% have an abnormal finding, is endophthalmitis, and 61% had an echocardiogram, one of these with endocarditis data. 100% of Candida parapsilosis were fluconazole resistant, and I want to show you our historic distribution of Candida species that were Candida albicans, followed tropicalis and glabrata, the most species that we are isolate. And previously, only 6% of Candida parapsilosis were fluconazole resistant. For this, now a clonately study is pending, where here 96% receive antifungal treatment, 86% with receive echinocandin, and 40% anazole. 29% mortality was registered versus 1470% versus, of patients with non-invasive fungal infection. Well, in this graph, I want to show you a bi-monthly rate of invasive fungal infections per 1,000 intensive care unit admissions. And first, in the timeline, the X line, we can see the time when dexamethasone starts as a standard of care. And we can look 2 times of Candida or Candidemia outbreaks and two times of Kappa outbreaks. Well, what was concluded and done after this finding in our hospital about candidemias, infection control strategies, a critical care personnel education start, and safe intravenous lines management, and double growth eradication and high hygiene. About aspergillosis, we suspended particulates measurement and revision and replacement of ventilation filters on reconverted critical areas. About COVID-associated mucormycosis, we have only 3 cases, 2 pulmonar and 1 rhinosinusal. 2 were male and only female. 2 had obesity and 2 had diabetes, 2 type diabetes. The diagnoses were with culture in 2 cases, and in 1 case, a positive PCR mucorgenius was positive. 3 cases received treatment with antifungals, and only case stay alive. Well, finally, we made a mortality analysis in which I can show you the possible factors associated with the mortality. And we found, after a multivariate analysis, that who died were, those who died were more probable male, older, and the most had kappa, and less frequently receive antifungal management. With this, we conclude that invasive fungal infections occurred in 8% of critical ill COVID-19 patients. Kappa was the most frequent, mostly diagnosis through tracheal aspirated culture. Only 22% had a positive serum galactomannan. We faced too limited availability of bronchoscopies because of aerosol generating procedures concern, and several arts precluding the procedure. And for this, we are on an ongoing study to compare tracheal aspirates galactomannan versus bronchoalveolar galactomannan to measure the accuracy. And one thing important is that infection control practices reinforced during outbreaks, especially frequent revision and maintenance of ventilation system, and catheter-related candidemia outbreaks due to the gaps in infection control. Important is a central line bundle reinforced, double growth practice, and hand hygiene reinforcement. Novel strain of fluconazole-resistant Candida parapsilosis involved in the most cases, and a single case of rhinosinusal mucormycosis in a patient with diabetes and steroid treatment. Despite an elevated prevalence of uncontrolled type 2 diabetes and unregulated steroid use in Mexico, warrants high suspicion of this invasive fungal infection. Well, increased mortality was seen in older patients with kappa who did not receive treatment. For this, increased awareness and early diagnosis and treatment of patients with kappa may impact on mortality, and invasive fungal infections remain a challenge, especially in the context of a collapsed healthcare systems. Well, I want to thank the whole team, but especially to my chief and mentor, Dr. Fernanda Gonzalez, and all the people who work with us. Thank you, everyone.
Thank you very much, Dr. Roman-Montes. Very interesting work showing basically the epidemiology of IFIs in high complexity reference center in Mexico. And this really underscores how we need to work together and cross borders to create some of this data. I have a quick reminder for those of you that are not monitoring the chat. We are going to be sending a survey after the meeting, and we need to hear your input for planning future meetings. And I'm going to turn it over to our convener, Dr. Papas, to close out the session.
Okay, thank you, Luis. And thanks to all the presenters who took their time to participate in this webinar and share their information. It was an outstanding session for a lot of new data. And learned a lot. I'm sorry we didn't have more time for questions. I suppose what I can suggest is that for those who have unanswered questions, to submit them and we will disseminate them to the speakers, the appropriate speaker, who then can answer those questions directly, or they'll answer them through me. But in any event, I apologize for not having more time. We just ran a little over, but it's approaching 3:30 now, and so I think we'll convene this seminar. I want to thank everybody from MSGERC. I'd really like to thank Castle and Associates, who organized this call, the CDC for their sponsorship and helping us to do a lot of these educational programs, Tom Chiller especially, but all of those in the Mycotics branch. I'd like to also thank Lisa at Terra Nova and the work that they've done in being an educational partner with us. So with that, I'll end the meeting and thank everyone for participating. We had a great turnout. And again, submit your questions, and we will try to get them answered as expeditiously as possible. Okay, thank you again. Have a great day and a great week.